Good afternoon, Mr. Stephen.
Good afternoon, my lord. The next is Ruth Wakeman.
Good afternoon, Mr.
Good afternoon.
Right, my name is Stephen.
Thank you, my lord. Could you confirm your full name, please?
Ruth Wakeman.
Thank you. Your age and contact details are known to the inquiry, so I won't ask those. I've already provided a written statement. The inquiry's record reference number for that is SCI WT 0470-5 zeros and then a 1. Are you happy for that written statement and the to form the inquiry?
Yes, I am.
Thank you. Are you happy for that evidence to be recorded and published? And everything you've said in that statement will be taken into account by the inquiry, even if we don't touch on every single aspect of it in your evidence this afternoon. And finally, just a reminder, there is a restriction order in place, so please don't name any specific individuals when you're giving your evidence.
Okay.
Thank you. I can see from the badge you're wearing, but I'll ask you anyway, what's the organisation that you're representing today?
I'm representing Crohn's and Colitis UK.
And what position do you hold within that organisation?
I'm Director of Services, Advocacy and Evidence at the charity.
And how long have you held that position for?
I've been working there since October 2019, so about 4.5 years.
And what does that role involve?
So I'm responsible for everything that we provide for people with Crohn's and colitis. So that includes our services such as our helpline, our online information, also our policy and our advocacy work on behalf of patients, our work with health services, and also our funding of research and our work to support research into the conditions.
Thank you. And the charity representing is a UK charity, is that correct? It covers both Scotland and England.
Yes, that's right. We're a UK-wide charity, so we cover all 4 nations.
Thank you. Okay. And what services more generally does your organisation provide to those with Crohn's or colitis?
So we're often the first port of call for people who are newly diagnosed, for example, and their friends and family. So we have a huge amount of information on our website, so everything that somebody with Crohn's and colitis would want to know. So what the conditions are, what the likely, what may happen to them with the condition, the treatments, information about surgery, and then also lots of information about the impact of the condition on people's lives as well. So thinking about education, employment, transport and travel and so on.
Thank you. How many people in Scotland are there living with Crohn's or colitis, to your knowledge?
So there are no accurate records, but research that we've commissioned suggests there's over 50,000 people living with Crohn's and colitis in Scotland. So that's about 1 in 103, and that's actually a higher prevalence rate than there are in other parts of the UK.
Is there a particular reason for that, or that you're aware of? Or?
No, because the causes of the condition aren't fully understood. We're not clear why the rate is slightly higher in Scotland than it is in the rest of the UK.
And in headline terms, and obvious perhaps, but what are Crohn's or colitis? Can you expand? You touch on this in paragraph 13 of your statement, but just for the benefit of those watching.
Yeah, so Crohn's and colitis are very serious illnesses. They're lifelong illnesses and there is no cure. And you can be diagnosed at any age, but many people are diagnosed before they're 30, so about 1 in 4 before they're 30. So that means that people are living with these conditions all their lives, and they're relapsing remitting conditions. So people may have a period where they're well, when perhaps the conditions are controlled by medications or by surgery, and then they have what is known as a flare, where the conditions get much worse. And the symptoms can have a really severe impact on people's lives. So we're talking about frequent and severe diarrhea with blood, so maybe 20, 30 times a day, a lot of pain, a lot of fatigue, and other parts of the body can be affected as well. So you can see if you've got symptoms like that, it's actually very difficult to carry on with your normal life.
And I think you say in your statement at paragraph 13, there is no known cure for that. So how is the condition treated?
Yes, so there isn't currently a cure. The conditions are controlled by medications. So these are sometimes known as biologic medications, immunosuppressive medications. People often have to try several different medications before they find one that works for them, and then the medication may stop working after a period of time. So you can see there often isn't a longer-term solution for many people. And surgery is often used as well. So many people could end up having surgery at some point in their lives, and surgery can sometimes be the answer for people, that it can completely relieve their symptoms. For some people, though, it's repeated surgery. And we're talking about major surgery, so removal of part of your bowel and perhaps having to use a stoma bag, either permanently or temporarily, while your bowel heals up again.
Thank you. We'll perhaps come on to some of the impacts that the pandemic might have had on the things you just outlined in a moment. If we can start, though, just going back to the start of the pandemic and the impact upon your organisation. As a charitable organisation, what effect did the pandemic have, for example, on your fundraising abilities?
Yeah, so there was an immediate impact on the charity, as there was with many other patient charities, in that at the time most of our income came from fundraising events, so things like the London Marathon, Great North Run and so on. So almost overnight, as all of those events shut down, we were looking at potentially no income to keep the charity running. So we had to make some very difficult decisions. We put most of our staff onto furlough, and we focused on keeping the essential services that people with Crohn's and colitis would need during the pandemic. So that was provision of our online information, keeping our helpline going, because the helpline became more and more important to people with Crohn's and colitis throughout the pandemic. The staff that were left all took a 20% cut in hours and a cut in pay, and some of the senior team, myself included, took a pay cut, but carried on working the same hours or more hours because of the crisis that was ongoing.
You mentioned a helpline. What sort of queries were you receiving on that helpline? What were people concerned about at that time?
So the helpline has always been really important for people with Crohn's and colitis, but it assumed a new importance during the pandemic because people couldn't get through to their teams in hospital, and so they literally had nowhere to turn. So we had an enormous increase in calls, almost overnight actually, from March 2020 onwards. People would be calling up desperate for information, so they wanted to know, were they more likely to catch COVID? Were they more likely to be severely affected? And of course, if you remember at the time, there was a really strong fear that people were going to die, and people did die, of course, with COVID. So there was, I think it could be safely described as panic for many people with Crohn's and colitis. They had no idea what this meant for them. They couldn't get hold of their teams in the hospital, the GPs weren't able to help, and so they turned to us as a first point of call for information.
You used that word panic, and you say that in your statement at paragraph 35. You talk about immediate panic sort of setting in. What information was out there for those with Crohn's or colitis in terms of the risk of them catching COVID? What was available at the start of the pandemic to them?
So at the start of the pandemic, there was literally no information at all. Nobody knew what this meant for people with Crohn's and colitis. And if you think that Crohn's and colitis are known as immune-mediated conditions, which means there's a dysfunction of the immune system in the gut, so immediately you have a suspicion if your immunity is affected. Does this mean I'm more likely to catch COVID? I'm more likely to be more severely affected. I'm more likely to die. And then on top of that, if you think about the medications that are used for Crohn's and colitis, they often suppress your immune system. So again, that added to your concern if you had Crohn's or colitis. And also immediately patients weren't able to get hold of their clinical teams at the hospitals, and these conditions are mainly treated in hospital. So they couldn't get hold of any information. They may have been in a flare at that point, they may have been at an early stage of diagnosis, and they felt very abandoned and alone at that point.
Thank you. Why, in your view, did that information gap exist, do you think?
I think Crohn's and colitis is not generally well recognised or understood, so lots of people don't know what Crohn's and colitis are. Because the conditions are often treated in hospital, the GPs may not have the information that they would need to support people with Crohn's and colitis. And there were no records available, so nobody knew who had Crohn's and colitis, nobody knew who was on immune suppressant medication, and that caused so many problems as the pandemic went on. First of all, identifying who was at risk, then later on who would be eligible for prioritisation for vaccines and boosters, and then towards the end of the pandemic, who was eligible for prioritisation for treatment if they caught COVID as well. So there was a huge information gap for people with Crohn's and colitis.
Could you say at paragraph 43 of your statement, as you just mentioned, there was no centralised way of identifying those at highest risk? Is that a state of affairs that's been rectified now? If we were to face a similar pandemic again, is this a problem that would now be defunct? Or?
Yes, this would exactly be the same problem again if there was another pandemic. So it sounds unbelievable, but there is no way of knowing, there's no correct centralised way of identifying people who had the conditions and people who had the conditions and were taking immunosuppressant medication. And we were desperately trying to find out at the time. We knew that the letters going out about shielding were incorrect for many people, so we had lots of people contacting the charity to tell us that they'd either received a letter to say that they were very high risk when they knew that they weren't, or vice versa, that they knew that they were high risk and they weren't receiving a letter. And we knew the letters were incorrect because we'd worked with the British Society of Gastroenterology, who developed a risk grid. And what had done is they'd brought together expert clinicians, and by professional consensus, looking at all the information that was available at the time, they classified whether somebody would be considered at higher risk, moderate risk, or low risk. And then as the patient charity, we created a decision tree for our website, so patients could look themselves, use factors about themselves and their condition, whether they were flaring or in remission, and what medication they were taking. And immediately this disconnect became apparent between the official information that was going out or not going out in many cases, and the true position of what somebody's risk status was.
Thank you. And that lack of a centralised record, obviously the inquiry is interested in lessons learned. Is there a lesson learned there, do you think, for a future pandemic? The fact that there's a lack of a record, what would you be suggesting to the inquiry should change perhaps?
Yes, I mean, I think that is a really key lesson learned, because the impact on people was so severe. I mean, people were put at risk, people experienced harm, sometimes life-changing harm, for example, if they had surgery, emergency surgery, and so on. And so we know that it had a really severe impact on people, and of course people's mental health as well, with the fear. So we believe that there needs to be an accurate, centralised way of identifying people who are at higher risk in a future pandemic, and that would apply to people with Crohn's and colitis, taking immunosuppressant medication, but also to other conditions as well. And we worked with other charities who were in a similar position, for example, charities for people with blood cancer. And there's a disconnect between secondary care, the hospital data, and primary care, the GP data. So I think many people would assume, oh, my GP knows all the medication that I'm taking, but actually that is not the case. If medicines are prescribed mainly in hospital, as they are for people with Crohn's and colitis, the GP doesn't necessarily have that information. And what happened with the pandemic was GPs were the gatekeepers for access to vaccinations and treatments, but often they didn't have accurate information to work from. So there needs to be a better way of sharing data between primary and secondary care. And the impact, it wasn't just on patients. Clinicians ended up wasting an enormous amount of time. So we spoke to clinical nurse specialists working in IBD in hospitals and gastroenterologists, and they said they were, having to scurry around using Excel spreadsheets to try and work out a list so that they could send that in. And it seems shocking, really, in this day and age that there isn't a more accurate way of identifying people. And this would be exactly the same problem in a future pandemic.
Thank you. And obviously this inquiry is concerned with the Scottish Government's response to the pandemic, and you're a UK charity. The register that you talk about or recommend would be a good idea. Is that something you would expect to be UK-wide? Would the systems speak to one another? I'm thinking of practicality here, I suppose.
Yes, I mean, that would be great. The same problems occurred in all 4 nations, so it was a UK-wide problem, but it definitely was a problem that occurred in Scotland.
You mentioned earlier a risk grid, and we'll come on to that. Was that a response to the lack of information that you mentioned earlier? Was that the impetus for that risk grid to be created, the fact that those with Crohn's or colitis simply didn't know what their risk level was, for want of better words?
Yes, exactly. And the senior clinicians, people working with the British Society of Gastroenterology, immediately recognised that problem. And some emergency phone calls took place over that first weekend of the lockdown period. And everyone worked together really rapidly to create this risk grid. Which we know was accurate, and patients could use it to self-identify as well. But the problems occurred was because that grid wasn't recognised by the NHS or by the UK government, and so it would often conflict with information that patients were being sent centrally, so shielding letters through the NHS or information that GPs would be giving to them. And you can imagine how confusing that was for people at the time when there was so much fear, understandable fear, concern and panic, as I've said earlier. So there needs to be a better way of working with senior clinicians in the event that there's another pandemic like this, so that these risk grids can be recognised and that expert clinical opinion can be used and recognised by the government. Because it became a source of conflict, people would take their risk grid information to their employer, for example, and the employer would say, well, you haven't got an NHS letter, I don't believe you. Or the GP would say, no, I'm not going to prioritise you for a vaccine, you're not on my NHS list. So it caused a lot of unnecessary stress, worry, conflict, but also meant people just weren't being eligible for support and access that they needed.
So you've got these two information streams. You've got the risk grid on the one hand, the other messages, letters coming out on the other, sort of running in parallel, or perhaps like ships in the night.
Yes.
Did you, as an organisation, provide feedback to the Scottish Government about this conflict or a way to resolve that, this mixed messaging that was going out to those with this condition?
Yes, we did. So our policy teams wrote to all the governments across the 4 nations. We also lobbied. We worked with other charities. So at one point there was an informal coalition of charities of people receiving immune suppressing medication, many of whom had very similar problems. We wrote to the UK Vaccines Minister. We wrote to the Joint Committee for Vaccines and Immunisations, and we were continually raising the situation for people with Crohn's and colitis. However, what we found was every time something new came out, again, people with Crohn's and colitis hadn't been considered, and we would have to start our efforts all over again. And of course, as a UK-wide charity, this was quadrupled for us because we were having to do this 4 times across the 4 nations. So it was extremely difficult and ultimately very hard to get our point across. People with Crohn's and colitis definitely felt ignored, alone, forgotten through the pandemic.
Thank you. And for completeness, that risk grid was utilised by people in Scotland to the best?
Yes, it absolutely was, yes.
Okay. I wanted to turn now to paragraph 60 of your statement. You talk about the Crohn's and colitis community's reliance on highly qualified nurses, IBD nurses, and your reliance on those. How did the pandemic affect the role of those nurses?
So IBD patients rely hugely on nurses, and we have what are called IBD clinical nurse specialists. IBD is the umbrella term for Crohn's and colitis. So the clinical nurse specialists provide a really key role for people with Crohn's and colitis. They are the first point of call, so they man nurse advice lines in the IBD services. Many of them can prescribe, they oversee infusions, and they really fulfill a really valuable function in terms of supporting patients with appropriate information and advice, but also in helping to reduce unnecessary admissions to hospital. And I think because the role of IBD nurses was not clearly understood within hospitals, in the pandemic, they were immediately redeployed. So the advice lines were closed, they were redeployed onto COVID wards, and there was immediately then a drop in access to information and care. We've heard from clinical nurse specialists that many of them protested against this at the time and tries to raise their concerns within hospitals, but often it wasn't understood. And I do know of one clinical nurse specialist team in Scotland who actually started collecting data to show that the rate of unplanned admissions to hospital was going up as soon as their nurses were redeployed. And in that particular hospital, the nurses were deployed back to the IBD service. But that was quite unusual, and in many services, the nurses were redeployed for quite long periods of time.
That was going to be my next question, really, was to ask about the impact of that redeployment. So, with the unplanned admissions, was that because they were ill or needed to receive emergency care because of that gap, as you would be your view? Is that right?
Yes, exactly. So, because people couldn't get through and couldn't get proper medical advice, then they became seriously ill. So, it may be that they were flaring, so their condition had got much worse. It may be that their medication had stopped working. Maybe they were newly diagnosed and they hadn't yet been put on medication. And the impact for patients, there's a lot of evidence now that if Crohn's and colitis is not being well controlled by medication, the long-term outcomes for people are much worse. So you're talking about people needing surgery that perhaps they wouldn't have needed, and emergency surgery has worse outcomes than planned elective surgery. So these could have lifelong impacts on people ending up with parts of their bowel being removed, stomas permanently that perhaps wouldn't have happened if they'd been able to access care immediately.
And you touch on that, I think, in paragraphs 63 to 65 of your statement about operations being cancelled, things like that. Were there any other treatments or procedures that you would highlight that were affected by the pandemic for those with Crohn's or colitis?
Yes, so many people are treated with infusions, and they may come in every 6 to 8 weeks for their infusion of their medicine. If somebody is being started on a new medicine, they may need to come in more frequently to start with, so they might be coming in on a week, 3 week, 6 weekly interval. The hospitals tried to keep the infusion clinics going, but obviously there were issues with delays in people accessing their medication. But the other impact that we found, that people were so frightened because of the uncertainty of the situation for them and the fears about COVID being worse for them, that some people didn't attend their appointments and cancelled or stopped taking their medication because there was confusion that an immunosuppressive medication would mean that would suppress their immune response to COVID as well, which wasn't actually correct. So this lack of information, lack of being able to access medical advice and information to talk to somebody meant that this would have a really severe impact on people.
Thank you. You talk in your statement about conducting a survey, I think it's Life in Lockdown survey,
Yes.
done between June and July 2020. When restrictions began to ease during the pandemic, in your opinion, were those with Crohn's and colitis still affected by what was happening?
I think in some ways that's when it actually felt almost worse for people with Crohn's and colitis, because other people started to get back to some form of normality. But for people with Crohn's and colitis, they were still extremely concerned that they were going to be more seriously ill or were going to die. And if you think about the age range of people with Crohn's and colitis, they might be in school, they might be in college, they might be a parent of someone who is going in and out of school every day. They may be someone who's in a frontline role. So we heard from lots of people who were teachers, nurses, doctors, GPs, people working in supermarkets and on essential transport. So as some people started having to go back to normality, people with Crohn's and colitis were really, really terrified. And because they didn't have that official letter from the government or the NHS, all sorts of problems began to emerge with people being asked to do things that would have put them at risk. And also practical things affected people as well, so that all the public toilets were closed. So for someone with Crohn's or colitis, they often plan their whole lives around access to a toilet. And so where other people started going out and about, people with Crohn's and colitis felt that they couldn't because of the lack of access to toilets. So there was a real feeling at that point from people with Crohn's and colitis that they were being left behind. And you can imagine if you're a parent, you've got Crohn's or colitis, you're really concerned, and you've got a child, for example, that's going in and out of school every day, you would be really, really worried and fearful. And we had people isolating within their own homes from their children, for example, which obviously the mental health impacts of that as well were really significant.
Predicted my next question, because we've talked quite a bit about physical impacts, and that's exactly what I wanted to ask you, really, again, perhaps based on the survey results that you did, or indeed any other feedback mechanisms. What was the mental health impact for those with Crohn's and colitis?
Yes, I don't think we can underestimate the impact on people's mental health and their general well-being. So if you're living with a fear that you're about to die from an invisible illness, or you're much more likely to be really severely ill and hospitalised, then you add on top that you can't contact your medical team, you perhaps can't access your treatments, and then perhaps you've been waiting for an operation, you're in severe pain, you're going to the toilet multiple times a day, and then that operation is repeatedly being cancelled. You can see that the impact that that is going to have on your mental health. And then not being able to do some of the things that other people could do at that time to help their mental health, such as starting to go out when that was allowed and starting to see people when that was allowed because of the fear. And even a couple of years after the pandemic, we still had people calling our helpline who said they were still shielding because they were so frightened and they'd never had an official letter to say, it's okay, you can stop shielding now. So that fear has had really long-lasting impacts on people's mental health.
You mentioned shielding, so let's talk about shielding. At paragraph 45 of your statement, you talk about there being huge confusion for people, and I think you've elaborated on this slightly already, but what would you attribute that confusion to, that lack of information that we talked about earlier, the lack of that centralised register? Is that, in your view, why there was confusion around the concept of shielding for those with Crohn's and colitis?
Yes, there was huge confusion around shielding, and I think most people would like to think they can trust the information they're receiving from the NHS or from the government. So it caused incredible uncertainty and fear when people weren't getting the correct information. And we know it wasn't the correct information because there was no way of correctly identifying people with Crohn's and colitis. So we know that 1 in 5 received the wrong letter, and we know that even a higher proportion didn't receive a letter when they should have received a letter. So that really undermined people's faith in the system and led to all sorts of practical problems as well. And we had a huge spike in calls from people ringing us saying, I've got a letter, I don't know why, what does this mean, do I need to stop going to work or whatever, and then other people saying, I can see from your decision tree that I'm high risk, or maybe even my gastroenterologist has told me at high risk, but the GP is telling me I'm not, and I haven't had a letter, and I haven't got access to that support and the protection that having that official letter would give. So huge confusion, distress, and also risk of harm to people as well.
You mentioned 1 in 5 not receiving the correct shielding information. What was the percentage in Scotland of those that weren't receiving that information?
It was very similar in Scotland, so that was really a UK-wide problem, and Scotland had exactly the same problem. And we've spoken to nurse specialists in Scotland, and they said that, you know, they were trying to find out how were people's details being pulled. Public health had no way of knowing who was on the medications, and they were desperately trying to find this information. We spoke to some gastroenterologists who said they had no idea where the data was coming from, but nobody had spoken to them about the patient lists.
And again, was the inaccuracy of these letters something that you were feeding back to the Scottish Government and other bodies?
Yes, that's right. We were continually raising the inaccuracies of these letters and the impact that having the wrong letter or no letter was having on people's lives, but also on their safety.
And was that feedback acted upon, to your knowledge, by the Scottish Government or others?
No, not as far as we know. I mean, there were no changes in the letters. One thing that did happen was we were contacted by the Scottish NHS to help with information in a letter. So people who were being sent a shielding letter and who had Crohn's or colitis, we provided some information to help with that letter. But we don't actually know if that letter was ever actually sent to people with Crohn's and colitis. And of course it wouldn't have helped all the people who were not getting the letters, who were inaccurately identified or not identified at all.
So again, are there any particular lessons that you would want to highlight to the inquiry on shielding specifically, of things that could be done better or differently next time?
Yes,
if there was a next time?
I think charities are trusted sources of information, and you know, we believe we should be treated as partners in the dissemination of information. We're there, we've got channels, we can reach people that official channels can't reach in many cases, but we were not getting the information in advance of the general public. So quite often it would be something on BBC News, and we would be rushing around trying to update our website, ×4 because all the information was different from the 4 nations, and the timing, as I've mentioned in those statements, it often seemed to be late on a Friday evening when our staff teams weren't necessarily working, and it meant we couldn't get ready for the next influx of inquiries and concern coming through from people contacting us through the helpline. So we would really like government and the NHS to work with patient charities. We are trusted as sources of information, and it would be really good if we could be considered and included so that we could help with getting information out to people quickly in future.
And on that issue of guidance being issued, what was the resource and time commitment your organisation was having to undertake to keep on top of all this information?
It was absolutely huge. So we basically, we have an enormous amount of information. It all goes through checks with medical professionals, and we update our information on a rolling 3-year period to make sure it's always accurate and up to date. We are still not back to updating on a 3-year basis. And that's because the entire information team for well over 2 years totally only focused on COVID. It was a constant process of updating our information on COVID, and then of course once the vaccinations and the boosters started, we had to continually update that information. When were the boosters coming out? Who was eligible? That was different. And then, of course, towards the end of the pandemic, when treatments became available and some people were prioritised for access to treatment, the same confusion and misinformation arose. So we were having to keep working on that information, but also our policy teams as well, to continually keep raising these issues with decision makers in the NHS and in the 4 UK governments as well.
You mentioned vaccines, and that was actually one of the final things I wanted to ask you about, because at paragraph 86 of your statement, you say it felt like crisis mode ramped up again when the vaccine started to become available, and I think the word I regularly see used in your statement is that of battle, you know, having to battle. Why did you feel that way, and why did it feel like a battle in the context of vaccines?
So it was obviously a huge relief for people in the UK when vaccines started to become available. However, for people with Crohn's and colitis, because their immune because they're immune-mediated conditions, they were obviously considered more at risk because of their medication, or perhaps if they were in a disease flare or taking steroids. So they should have been prioritised for early access to the vaccines. However, that didn't happen. And the same issue arose again. There was no accurate way of identifying who had Crohn's and colitis and who was on immune suppressant medication. So we knew, and we could tell from the risk grid, and the clinicians were confirming that people with Crohn's and colitis should have been in the priority groups for earlier vaccination. Some of them were, but many of them weren't. And one of the reasons for that, there's something called the Green Book, which is a sort of NHS Bible that is used to identify access for vaccinations. And Crohn's and colitis wasn't mentioned by name in the Green Book. And that meant that GPs, who were the gatekeepers really for vaccines, would be turning people with Crohn's and colitis away because they would believe, and not that their fault that they believed this, that people weren't actually accessed for early vaccination. So that became a big problem. It was actually a historical problem because we've had a very similar situation with flu vaccines for many, many years. And in fact, Crohn's and colitis is still not mentioned by name in the Green Book chapter for flu. But it took on a whole new significance with COVID. And then once the boosters started to become available, there was a concern that because people were taking immunosuppressant medication, they wouldn't have a good response to the vaccine and they would need more boosters and more frequent boosters. So again, they should have been prioritised for access to boosters, but many people with Crohn's and colitis weren't. So you would have people who knew they should have been getting access. Their gastroenterologist or their IBD nurse would tell them they should have early access, and when they went to the vaccination centres or to their GP, they would be turned away for vaccination. So we wrote to the JCVI, which is the expert body that advises the government, and their advice is included in the Green Book. They didn't reply to us, or we get a very short reply saying we're looking at the evidence. I'm pleased to say now that Crohn's and colitis are mentioned in the Green Book chapter for COVID, but that actually happened fairly late on. And I think what would be really key is in a future pandemic, there'll be another new chapter on whatever disease is calling that pandemic. And we need to make sure that people with conditions like Crohn's and colitis are listed by name. And as we've said earlier, that there's a correct way of identifying people who need prioritising for vaccines and prioritising for access to boosters as well.
Given everything you've said, do you think there was sufficient regard had to those with Crohn's and colitis when forming the response to the pandemic by the Scottish Government?
No, absolutely not. I think people with Crohn's and colitis are often forgotten. I think that the NHS and the government focused on cancer, which is obviously extremely important, but there was a lack of recognition that there are other serious conditions where people often need hospital treatment, may need surgery, and that those people should be considered as well in the event of a pandemic, because it really felt to people with Crohn's and colitis that they were completely forgotten. And it also felt to the clinicians caring for people with Crohn's and colitis that they were redeployed into other areas, and there was no recognition that their patients could become really very seriously ill without their advice and support and treatment.
Thank you. I didn't have any further questions for you, so really, if there's anything that you think we've missed or skipped over, this is your opportunity, I suppose. Any lessons learned, or you feel like there's something you want to share with the inquiry, now is the time.
Thank you. I think there are three main areas which I have outlined earlier. The first is recognising charities as trusted sources of information, and governments working with us in the event of any future pandemic, or in fact any public health emergency. Involve us at the start, keep us updated, use us as ways of reaching people, and I think really consider charities as partners in helping to support people in the event of any future crisis. I think as well, It's about making sure that there's accurate data. It really does seem unbelievable in this day and age that there is no way of accurately identifying people who either have a condition like Crohn's and colitis or who are on medication that may put them at a higher risk. And there needs to be a way of accurate data so that people can be protected in the future in the event of another pandemic. And I guess the third area for us is around vaccinations. We need to make sure that the JCVI are considering all conditions and that that information is really clearly set out in the Green Book so that that can support people working in primary care, working in GP practices, so that they can correctly identify people for vaccinations and boosters in future.
Thank you very much.
Thank you.
Yes, thank you very much, Ms. Wakeman. I'm very grateful.
Thank you.
Right, Ms. Stephen, we are again a little bit ahead of schedule, so shall we try and come back, if possible, at 3 o'clock?
Okay. I think it's Mr. Dunlop next, so I will check he's in the building, but yes.
Good. Thank you very much
you.
indeed. Now, good afternoon, Mr. Dunlop.
Good afternoon, my lord. There's one witness remaining this afternoon, and that's Miss Claire Cairns. And for the benefit of your...
Miss Cairns.
Hello.
Thank you. And for the benefit of your record and that of the transcription, the statement number is SCI WT 0434 dash, and it's 5 zeros and a 1.
When you're ready, Mr. Dunlop.
Thank you, my lord. Good afternoon, Ms Cairns. You've provided the inquiry with a signed statement. I think that's correct?
That's correct, yes.
And you tell us in paragraph 1 of the statement that you're the director of the Coalition of Carers in Scotland, which I'll refer to as the Coalition in my questions today, just for brevity. And in paragraph 4 of your statement, you tell us a bit about the Coalition, including that it represents and advocates for unpaid family carers and local carer centres. I'll have some questions about local carer centres later, but can you tell me what a local carer centre is?
So in Scotland, there is a network of local carer centres. There's one in every local authority. And possibly the best way to describe them is a one-stop shop for carers. So they are part of the third sector, the voluntary sector. They are generally funded through local authorities via contract, and they have other funding through fundraising. Carers can refer themselves, or other organisations can refer into them, and they provide a broad range of services, including information, advice and support, peer support, access to short breaks, counselling, advocacy, a whole range of different services.
Okay, thank you. And I think the key point I just want to take from that, they're provided by the third sector. They're not local authority provided.
That's right. Well, there's one or two which are local authority, but on the whole, they're generally third sector.
Thank you. And does the Coalition represent paid carers, or is it just unpaid carers?
It is just unpaid carers,
okay.
And our membership also includes the local carer centres.
And how many, I suppose that then you may have organisational members and you may have individual members. Do you know your membership numbers?
So in terms of organisations, approximately 50, and then in terms of carers, about 200 or so. The carers who tend to be members tend to be ones who are more involved in local strategic planning, you know, for example, local carers voice groups and so on, and having a voice in terms of the development of services in their local area.
Thank you. And at paragraph 27 of your statement, you tell us that most unpaid carers do not engage with services. Am I correct that there's no accurate register of unpaid carers?
Yes, that's correct. There are different ways in which carers are registered. So, for example, whenever it came to letting carers know about the vaccine and it was their time to come forward, various ways of contacting carers. One was through carer centres themselves. They have quite often large lists of carers registered with them. But I would say estimate that's only about 10% of the carer population if you go by, you know, statistics in terms of how many carers there are in Scotland. There's also carers who receive carers allowance, and so that was another route to look at carers. Some GPs have registers of carers, but there is a large cohort still who wouldn't be registered anywhere.
Okay, maybe just one question arising from that. Does the absence of a national register, does that cause any difficulties for either your organisation or unpaid carers?
I mean, certainly there's been talk in the past it would be helpful to have a national register of carers. One of the difficulty is carers identifying themselves as carers. So very often people with a caring responsibility might not recognise that for quite a long time. And because of the familial relationship, they may say, you know, I'm a parent of a child with a learning disability, I look after my mum, but they don't necessarily recognise themselves as being a carer.
In terms of, you're talking about carers, can I just to be absolutely clear, when you use the word term carer in your evidence today, you're talking about unpaid carers?
Yes, I probably will use the shorthand of carer
That's
rather than
absolutely
unpaid care,
fine.
but it will be, unless I would tend to use the phrase care worker when I'm referring to people employed.
Thank you. And you say at paragraph 47 of your statement that the primary objective for the coalition was getting information out to carers. I suppose two questions, or maybe three, arise from that. What information was it that you were trying to get out?
Generally speaking, because throughout the pandemic, and particularly at the beginning, there was so much information coming out, primarily from the Scottish Government, on the rules around what you could and couldn't do. And because there was quite a nuance in terms of how that impacted in carers, what we did was we tried to filter the information as much as possible so that we could give carer centres and carers the information that was most important to them.
And you were filtering it, and how were you then cascading it down? Was that through emails? Was that through face-to-face? How were you actually getting that information to the individuals and the care centres?
So we used a variety of ways. We quite quickly set up a WhatsApp group for carer centre managers, and that was pinging away daily. So we got information to them very quickly that way. We also did a weekly briefing for them, which gathered all the key information together and sent that out. We had meetings throughout, for example, for carer centre managers. They met online throughout the pandemic. And we had some learning and sharing groups for specific members of staff. So that was like the carer centre side of things. The idea was then that they would cascade that to their carers. So that was one route. And then we're very active on social media. So through our own Facebook account, for example, that was quite a hub for carers to get information quite quickly.
Okay. And just moving on to paragraph 50, you state that carer centres remained open during the pandemic. Now, we've heard evidence earlier in the inquiry in relation to day centres which were operated by local authorities, which essentially, I think, to use my words, not the witnesses that have spoken previously, essentially closed during the pandemic. Can you perhaps explain to me if there's a difference in how they operate, and in particular how the carer centres which you're talking about were able to remain open, but the day centres run by the local authorities were not able to stay open? I appreciate there's a few questions in there, but perhaps if you can distinguish them first in the first place.
I think the major difference was, although carer centres pre-pandemic would have carers walking in the door, the way they delivered services during the pandemic had to change, but they were able to put a lot of their services online, whereas day centres weren't able to, because they're very much a kind of face-to-face service where somebody would come along and receive a service, and then carers would receive respite through that. So how the carer centre did it, and I have to say they were absolutely fantastic during the pandemic. They worked even harder and they extended the services they normally provide. So quite early on, I think April, May time, they received, there was a fund set up from the Scottish Government which gave them money to purchase equipment to make it easier for them to put their services online. So even before that, they had kind of, as far as they could, the staff were working from home with whatever equipment they had. But that allowed them to do things like purchase iPads for staff or laptops so they could continue to work from home. Zoom licenses when Zoom came up and everybody was able to suddenly meet online rather than just phone calls. And they used a variety of methods. So I know very much in the beginning they phoned around a lot of their carers to say, how are you? Are there anything you need in terms of practical things like getting shopping, etc.? How are you feeling about all this? So just really keeping in touch with people and making sure that they were okay and checking in with them. And most of them did that throughout the pandemic with the carers. And then as time went on, they developed all sorts of interesting things like online groups, book groups, things which were, quizzes, etc. Lots of things that the rest of us probably did with our family as well, but just to keep that contact, keep the peer support.
And I appreciate that you're saying they use technology to keep in touch with the people that would use the service prior to the pandemic. Is there a reason why, I'll call them daycare centres couldn't have approached the issue in the same way and had online bingo or games or whatever?
I mean, I can't speak for day services because they're not our members. So I wouldn't like to speculate on that. I know that, generally speaking, the carer centres always had a variety of ways of communicating. And so that was extending what they normally did.
Staying with carer centres, you say that the carer centres provided PPE support. What do you mean by support?
So what happened was, very early on in the pandemic, one of the first things that happened was the need for PPE, and that included unpaid carers. So one of the first things were concerns expressed by carer centres and members about carers not being able to get hold of PPE, and concerns of passing on COVID to the people they were looking after. That was resolved, I suppose, relatively quickly. Within about 6 weeks, the PPE hubs were set up for social care. And each area had a PPE hub which delivered it to various social care settings and also unpaid carers. And the way carer centres worked was they were the referral source for carers. So a referral kind of protocol was developed. Carers were able to phone their local care centre, get in touch with them, and if they were eligible for the PPE, then it was arranged for delivery either directly through the hub, or sometimes the carer centres themselves were involved in delivering PPE directly to carers.
And a couple of points arising from that. You said if they were eligible, what was the test for eligibility?
There was a whole checklist, and one of the first questions was, do you deliver personal care? So that was one of the first things. The PPE was gloves, aprons and masks, so it was particularly for people delivering personal care. There was, like I say, a whole checklist, but that was generally the first thing.
And in terms of the PPE that was delivered, was that suitable for purpose, or do you know?
I believe so. There was some questions around whether the mask could have been a higher level that came out later on, but certainly the PPE that was provided was very welcome, and the system worked pretty well until the hubs closed.
And were those masks the blue surgical masks that we're kind of familiar with?
Yes, they were that level.
And you said that the PPE could be delivered. How quickly was that delivered? Was there delays in getting PPE to carers?
I wasn't aware. We did check in with carer centres every 6 months or so to see if there were any issues, and there didn't appear to be. Once the supply route was kind of set up, and once the hubs were set up, very often carers were getting regular orders, I don't recall any issues around that once things had sort of settled down and they were up and running.
At paragraph 57, you go on to discuss shielding and clinical vulnerability, and you tell us that many unpaid carers were shielding due to concerns that if the carer contracted COVID, this would then be passed to the family member who was being cared for. Did this mean that effectively there was people that were voluntarily shielding that weren't on the shielding list?
Yep, absolutely. In fact, and you could say that in two ways. I mean, the shielding information came out in early April, I believe, but there were still quite a lot of people who believed themselves to be vulnerable who weren't on the shielding list. And then a helpline was set up for them as well, kind of relatively early on. I think that was sort of towards the end of April. So there was quite a lot of people who believed that they were more at risk from COVID who may not have been on the official shielding list. And then in addition, carers, because obviously when they're providing particularly personal care, but care within the home, if they contracted COVID, there would be a high risk of them passing it on, even if the person themselves was shielding. If the carer still has to go out and get shopping and so on, there's a higher risk of them passing it on. So we knew, and the carer centres reported, an awful lot of carers were doing their absolute best to do the equivalent of shielding.
And you said a helpline was set up. Who set that up?
The Scottish Government set up a helpline towards the end of April, and I believe that was to give advice and support to people who, I'm not sure whether it was people on the shielding list, but it was certainly as well people who had potentially more of a risk factor because of ill health.
And you tell us at paragraph 67 about that the Scottish Government didn't initially accept that people with Parkinson's disease should shield, but thereafter Parkinson's was a condition that was added to the list, and I think that was following the Scottish Government having been provided with more data. Is that correct?
Yes, so it was the JCVI who made the decisions on the shielding list, and obviously I'm sure they were learning as they went, depending on the impacts of COVID on different conditions. So that was just one example. There were various changes that happened throughout the pandemic of some conditions that were put on that weren't on previously. And that particular case, it was one carer in particular who was campaigning, and we were kind of, she was very involved with the coalition. It was particularly as well around antivirals. So Parkinson's disease wasn't on the antivirals list until much later. I think it went on, I can't remember the exact date, but I think it might have been 2022, and eventually it was on the antivirals list.
And what was it the coalition were doing to support people that were trying to get other conditions added to the list?
So, for example, in that particular case, there are a few things we did. In actual fact, communication around carers was pretty well set up in Scotland before the pandemic. So there are several national care organisations, of which the Coalition of Carers is one. And there's also a carers policy unit at the Scottish Government, and we've always worked very closely together. So during the pandemic, we were actually meeting weekly. And so with the information we were getting directly from carers and from local carer centres and the weekly meetings, we would raise any issues that had come up. And then they were able to, take them up the line to whoever potentially ministers if decisions had to be made. So those communications were already in place. In addition, with the particular carer who was campaigning around Parkinson's disease, we also had during that period 2 meetings with Hamza Yousaf around it where this issue was raised, and he said he would pick it up outside. So we also were able to at times meet with ministers of or politicians.
Paragraph 75, you talk about PPE again, but you also identify that COVID testing kits were not initially available. You say a lot of these problems eased over the early months, excuse me, but a great deal of this was because community volunteers. What was it that the community volunteers were doing in relation to the COVID testing kits?
I think it was more in relation to delivery. Some of the areas were getting PPE kits and I think tests as well delivered by volunteers, so it was just a case of dropping things off. But also there were a lot of volunteers involved in things like picking up shopping for people, which was really important, going back to people wanting to shield and lower their risk. So that kind of thing. It was very much locally driven, so each area would have had its own arrangements. But for example, I mean, my own mum in the Borders, she is in extra care housing, so we were able to get a volunteer to pick up her shopping and drop it off.
We heard from a witness, I'll say a couple of weeks ago, it may have been longer, who lived in one of the islands and talked about the community spirit. Was there a difference, or were you aware of any difference between communities kind of pitching in and helping, depending on whether it was a city centre or a rural or an urban? Was there any kind of, did you notice a distinction between the community pitching in different areas?
I don't know if I have that level of detail. My kind of general impression from carer centres was that there were good volunteer networks in every area. There may have been the odd area where there wasn't quite the same response, but I'm not aware of it.
From paragraph 80, you discuss infection control, PPE testing and vaccinations. And you tell us at paragraph 82 that you were on the Scottish Government PPE advisory group. Can you tell me what type of topics were discussed and decisions taken at that group?
So that was specifically for the PPE hubs, the social care hubs. So initially it was a lot about supply and increasing the supply. They had to look at what amount of PPE they predicted would be needed, and then it was making sure that it went out to different communities, and then laterally it was around how long the PPE hubs should be left open and what other arrangements should be made in terms of PPE being sourced differently from that point onwards, and going back to what used to happen with organisations sourcing their own PPE rather than it coming centrally.
In terms of, you said one of the issues discussed was how long they should stay open. Jumping forward, I'll come back, but jumping forward to paragraph 87, you tell us that the hubs closed. When was that? Do you remember?
I think I made a note of it. Let me just have a wee look. March 23.
Okay. And at that time, in March 23, was PPE still required, or had that for unpaid carers?
It had really dropped off, so it's something that happened quite naturally, I think, where carer centres were getting fewer and fewer referrals, and people who had been receiving it didn't require it any longer. What happened after the PPE hubs shut was each health board was required to continue to have a route to offer carers PPE for another period of time. I can't remember how long that was for. And again, that there still wasn't a lot of demand, so that has now ended.
Okay. And there was no charge for the PPE?
It was free.
It was free. In paragraph 91 of your statement, you state that the arrangements for the supply of PPE to unpaid carers in England weren't as good as arrangements in Scotland. Can you just tell me, you've told us obviously what the arrangements were in Scotland, unless there's more to say. What was it that Scotland did better than England?
Well, again, this is just a personal opinion, and that was just from
what
what I saw on the news.
That's what we're here to listen to.
Which everybody else saw on the news as well, just in terms of how they sourced it and the amount of money that went to private businesses, which didn't happen in Scotland. So that's kind of in terms of cost. I don't know if there's been a cost analysis, but I would imagine it was a lot more money was spent in England. I thought the sourcing and then the hubs worked really well once they were set up and running.
And you go on to discuss vaccinations at paragraphs 93 through to 105. And in paragraph 93, you say that you tell us that the coalition approached the government as carer groups were not on the list for early vaccinations. What was it that the coalition did in particular?
Well, as mentioned before, we had the weekly meetings with the Scottish Government. There were some meetings we had throughout that period with ministers, and so even from before the vaccine was actually created, we were saying when there's a vaccine, you know, really need to make sure that carers get it as soon as possible because of the situation with them shielding and putting their lives in pause. Of course, back then, whenever we talked about vaccination, we thought it was almost like immunisation. We thought once you got it, you'd be clear, which didn't turn out to be the case. However, obviously, it does give people a lot of protection. And so carers were extremely keen to get it as soon as possible. So, yes, we were advocating for it. And then whenever the vaccine was created and the government produced the priority list, carers were initially on it. So we were advocating for them to be one of the early priority groups.
And I think you discuss at paragraphs 98 and 99 that Jean Freeman announced that unpaid carers would be in group 2 of the priority groups for vaccination. Despite that statement or assurance, is that what happened initially?
No, so what happened was, I think the government came to the agreement that carers should be a priority group, and group 2 was social care workers. So initially we were told that carers would be in group 2 alongside them, and that had always been our argument that if you are giving social care workers vaccination, you should give unpaid carers the same level of support because they're providing the majority of care in Scotland. So Jean Freeman did announce it was group 2. However, I don't know what happened, whether it went back to the JCVI or what happened, but it was then they were bumped down to priority group 6.
And in terms of bumping down, as you put it, from group 2 to group 6, did that essentially delay the vaccination for unpaid carers?
It did, yes.
Okay. And did anything change, or did they remain in group 6? Did they remain in group 6? Or
yes, they did remain in group 6, which was the same level as people with underlying conditions.
And at paragraph 112, you move on to looking at overall impacts in your statement. At paragraph 112, you tell us that assessments for care support plans were suspended. I mean, firstly, can you tell us when you say assessments for care support plans, what are those?
So Scotland has the Carers Act that came in 2018, and one of the rights in the Carers Act is any carer can have an adult care support plan if they are an adult and a young care statement if they're a young carer. But during the pandemic, a lot of these things were suspended because of other priorities. So at that time, adult care support plans and young care statements were suspended. I mean, that didn't mean, for example, they could still contact their local care centre and get support, but it meant they weren't getting a formal assessment, which might have led to more services in normal times.
Okay. And those assessments, who would normally have carried those out?
Actually, the majority of adult care support plans and young care statements are done by carer centres in Scotland. Some are still done by local authorities, so they are the ones that are the duty bearers with the Carers Act, but they can pass that duty on through contract to other organisations. So a lot of them have done that with carer centres. So like I say, although carer centres weren't carrying out full adult care support plans, they were still, you know, somebody would phone and they would do their best to support them. It just wouldn't be the full assessment.
And was there, perhaps there isn't, but was there any impact as a result of those assessments being suspended?
I think probably the greater impact wasn't so much that the adult care support plans and young care statements weren't taking place. The greater impact was that a lot of social care services were suspended or halted or reduced during the pandemic.
And moving on to paragraph 115, you tell us that short breaks or respite was not available for carers. During what period was that suspended?
Well, it's quite difficult to quantify, but in terms of, I mean, pretty much as the pandemic started, a lot of these services were suspended or stopped because of risks of, you know, infection and so on. But as time went on and the government was saying you can start to open up some of these services, there was still a reluctance from local authorities to do that, or it could have been pressures on other areas of the system. But a lot of short break services and daycare and so on was very slow to open up in Scotland. And I think it is still the case that we aren't back to pre-pandemic support levels.
Just a few follow-up questions from that. They're very slow to open up. Do you, in your opinion, they have opened up earlier?
Yes, I mean, certainly, for example, even going back to sort of July 2020, or August 2020, actually, Jean Freeman sent out a letter suggesting that respite and day services could reopen with certain measures in place, but a lot of that didn't happen. And that is a kind of continual story throughout the last few years, that now we're in the situation that because there is a real workforce crisis in social care, even we're not looking at infection control or, you know, safeguarding anymore. We are looking at the difficulties in getting social care staff in to set these services back up again or bring them to the levels they were at pre-COVID.
In terms of when the short breaks, the respite wasn't available, are you aware of whether that had an impact on either the physical or the mental health of either carers or the people that they were looking after?
Yes, absolutely. I mean, I suppose there's a few things to that. I think a lot of carers initially, although, I mean, everybody was impacted by the pandemic, but carers without getting a break as well were particularly impacted. But early in the pandemic, they were accepting of that because they, like I say, wanted to protect the person they cared for. But as time has gone on and people would have accepted a break and wanted a break and they're still not able to access it, then absolutely it does have an impact on carers. And carers, you know, physical and mental health has always been, if you track it across the rest of the population, it's always been impacted by their caring role. But I would say, particularly now, having been through such a difficult period and still not often being able to access any support or the level of support they need, there are large impacts on the health and well-being of the care population.
And impacts on the health and well-being of that population in terms of requiring medical intervention. I'm just wondering if that places additional pressures on the already pressured NHS.
I mean, I suppose in terms of evidence, a lot of evidence we would get would be from local carer centres, who would say that people are coming, increasing them to them in crisis, and that the caring roles that they're supporting are a lot more intense and complex than they were before. And then you also have some survey evidence. So, for example, Carers Scotland, they do their State of Caring survey every year, and they look at impacts such as mental health impacts, physical impacts, etc. Their 2023 one, I mean, I think they're giving evidence as well, so they probably will give more of this, but their 2023 saw that 54% of carers had an impact on their physical health as a result of their caring role, and 37% of carers on carers allowance said their mental health was bad or very bad. So that would be worse than pre-pandemic times, although, there, like I say, there still would have been an impact for many people from their caring role. But you can chart that the caring population, as a result of that, there has been impacts.
And is it fair to say, we've heard evidence previously, that I suppose accidental unpaid carers arose throughout the pandemic as a result of there being less services available? Yes, absolutely. So, and you know, there are many examples and reasons for that. So one would be somebody in your family perhaps who was receiving sufficient care that you wouldn't have classed yourself as a carer, and you didn't have that responsibility of looking after them. Whenever services shut down, people had to take on caring roles for the first time, or they had to increase their caring role, which then maybe had an impact on their employment. Or there's a cohort of people who their family members became ill during the pandemic, either because of, you know, they would have anyway during a time period like that, or because of things like long COVID, or because of access to health services, I'm sure, as well, during that period. So for various reasons, there were more carers, and carers had to care for longer hours as well. And like I say, Carers Scotland has done a bit of research in that area. I think at one point through their survey work, they had calculated that the caring population had gone up to 1 million during the pandemic. From what? Do you remember? Well, the official kind of government figures are under 800,000, but around, I think it's 759,000. But that brings together various surveys, and we think that's probably slightly underreported because, as I say, people don't always identify themselves as carers. So the 1 million carers during the pandemic would have obviously had a different methodology. Moving on to, I suppose, a new topic, you discuss at paragraphs 116 and 117 of your statement that local authorities clawed back underspend on benefits that people were entitled to but couldn't spend as there were no services available. I suppose it might seem reasonable to some that if the money wasn't being used to claw it back. I'm just wondering if you're suggesting that something else should have happened, and if so, what should have happened? Yes, so that was primarily people who would have been receiving self-directed support option 1, which is when you're receiving social care support and you get a payment, which means you can purchase services yourselves. During that time, because some of the services they would have purchased weren't available, some people would have built up some additional money. But good practice during that time was the government produced self-directed support COVID-19 guidance, which said that people could use their direct payment more flexibly during that time in order to purchase different forms of support. And that might have been things like, there was all sorts of interesting things people did. So, for example, purchasing a bike so they could go for a bike ride and have a break that way, garden equipment so they could use their garden more, or, for example, employing a relative. That was opened up as well during that period because it was difficult to employ other people during that time. But there was a lot of variation in terms of how local authorities implemented that guidance. So for those who had their money clawed back, who weren't able to purchase a service, they may have been able to use that money, if they'd been allowed to do something else which would give them a form of a break. And if there was inconsistency by local authorities in the approach, some are clawing it back, others are, if you like, interpreting this COVID-19 guidance to allow them to, say, you said, purchase different forms of support or services. Did the coalition, was that something that they raised with the Scottish Government, this inconsistency amongst the local authorities? Yes, and we actually did 2 surveys around this. So we did one survey in July 2020. The new guidance came out in May 2020, so it's a few months after the guidance came out. And we simply asked carers to tell us about their experience in terms of using the new guidance, or how their self-directed support might have been used more flexibly. I mean, it was a snapshot. It was 208 carers who responded. We found that 60% had not been aware of the new guidance and being able to use their SDS more flexibly, which meant that local authorities weren't informing people as a matter of, route in terms of the new flexibility.
We also found only 28% of those who had been informed were told by their local authority. So they were hearing it from other carers, from organisations like ourselves. And of those who had requested to use their SDS more flexibly, 43% were denied. We repeated that same survey a year later, and there was some improvement in terms of people's awareness of being able to use their SDS more flexibly, and more people had been able to use their budget more flexibly during that time. So it went from 1 in 5 to 1 in 3 within that year. But there are still local authorities who didn't implement it as well as they should have.
Okay. And in terms of the sums of money, you gave us the example of buying a bike, which I suppose would be hundreds of pounds. Is that the kind of level of, in terms of money, sums we're talking about, or is it thousands?
I'm not sure. I mean, it would be individual budgets. But for example, employing a relative would have been a lot more costly, and probably more similar to the service the person would have got pre-COVID. But small kind of purchases, for example, I know a lot of people with parent carers looking after children with a learning disability, which was extremely difficult for them, getting away from their usual routines, having to make sure they kept them entertained and so on. Quite a lot of them, for example, purchased Disney subscription. That was something which was very helpful in terms of keeping them entertained. So it could be really small things which actually make quite a big difference, or larger things, like I say, like employing somebody.
And the last section of your statement deals with the lessons learned, and that's from paragraph 136. And I wonder, I'll just ask you a few questions about those. At paragraph 136 and 137, you identify that proper information and guidance should be issued at an earlier stage. Paragraph 138, you say that communities should be given more support. What do you have in mind when you say communities given more support?
I suppose there's two ways to look at this. If they'd been given more support pre-pandemic, and so there was, third sector was better funded, sort of making sure communities have the right assets in terms of generating volunteers and support based within people's communities, then that would have been more effective when the pandemic came in. I mean, I think that's something which always bears fruit in terms of investment in community-led support. And more support during the pandemic as well. I mean, most organisations, it tended to be the third sector who were generating a lot of this. So again, more funding during the pandemic, pre and post, would have helped in terms of that.
And you move on in paragraph 140 to discuss the success of the PPE hubs and that they could be set up quickly. Paragraph 141, you state in yours that the vaccination of unpaid carers could have been made more simple, including a single contact telephone number and clearer instructions. What were the difficulties that unpaid carers were struggling with in terms of the vaccination, the delivery of vaccination?
Yeah, so for most carers, they kind of access their appointment through the portal, apart from those ones who were informed of it by letter through carer centres, etc. And it tended to be that you would be allocated an appointment quite often in one of the large vaccination centres, and that worked for the majority of people. But for some carers it was problematic. So for example, leaving the person they cared for at home when there was no other support, or when it actually came to the person they cared for getting a vaccination, there were sometimes difficulties around that. So for example, somebody with a learning disability wouldn't cope well with going into a vaccination centre like that. So some people needed more support to get their vaccination, and health boards all did that differently. So as a national organisation, we were saying, what advice can we give people in these circumstances? Is there like one number we can give them to find out what they can do? And there wasn't one number, so each area was doing things differently, which made it very difficult to send out information on that.
And at paragraph 149, you tell us that local authorities were difficult to deal with as services stopped and the relevant people could not be contacted, and contact still remains a problem. Looking in terms of lessons learned, do you have any suggestions how that could have been improved during the pandemic?
I think people quite often just wanted, again, a number they could phone to speak to somebody, whether it was around, so for example, people who were wanting to use their direct payment in a different way. One of the issues was getting hold of somebody to ask permission to get an agreement. You know, they would phone, and if they had a social worker allocated to them, they had maybe moved, they weren't in the same place, and then trying to find somebody and, you know, actually get somebody who's able to make that decision was often very difficult.
Did your members experience a shift from telephone contact to email contact being the principal means of contacting bodies such as local authorities? I'm
not sure, to tell you the truth. All I know is that communication was often very difficult, whatever means they were using.
Okay, thank you. And just finally, you've identified your hopes for the inquiry, and we have that in front of us at paragraph 154. Before I thank you for your time, is there anything further you would like to add today that we either haven't covered or you think would be useful for the purposes of the inquiry and the task that lies ahead of the chair?
Yeah, I suppose just to make the point that a lot of the problems experienced by carers during the pandemic were because of the pressures in the system before the pandemic, and those pressures are continuing. And one thing I think carers would want to say was during the pandemic, we know that they were disproportionately impacted. They were very often left without support for long periods of time. They weren't able to get a break from caring. As I've said already, their health and well-being was affected. And throughout the pandemic, there was a hope that when it ended, there would be support there waiting for them to help them, you know, almost as a form of recovery. And we just haven't seen that happen. I think that the social care system is under even more pressure than it was certainly pre-pandemic, and I don't see it having improved much since the pandemic. You know, funding is increasingly being cut, packages are being cut. It's very difficult still for carers to get breaks from caring and the support that they need. So I don't know how much of this is partly to do with the pandemic, but it's to do with many other things, workforce issues, you know, Brexit, etc. But I do think that's an important learning point, that having been through such a difficult period of time, there should have been support there for carers whenever the pandemic ended.
Well, it just takes for me to thank you for your time both today and the preparation and participation in preparing such a comprehensive statement, which is evidence before the inquiry. Thank you for your time. Alert, yes, there's no further question. It's no further witnesses this afternoon.
Very good. Thank you, Mr. Glop, and thank you, Ms. Cairns. It's back to 9:45 tomorrow morning. So 9:45 tomorrow morning. Thank you.
Thank you.